Welcome, everybody. My name is Kevin Rennie. I'm the Chief Operating Officer here at NHS Providers. Very pleased to be here chairing an august panel. I'll ask them to introduce themselves in a second. This session is basically around how do we help and work with community individuals and leaders as we shape the next stage of the NHS's change towards system working. And I'm not going to say much at all. I'm going to introduce the panel and then chair at the end. So please do ask questions as you go through. Use the Q&A function. You'll be able to upvote and comment on those questions. And we look forward to hearing from the panel and then having some questions from the floor at the end. So without any further ado, I will ask each of the panel members just to introduce themselves briefly, and then we'll go into the content. So Paul, do you want to introduce yourself?
Hi everybody, Paul Devlin. I'm Chair at Nottinghamshire Healthcare NHS Foundation Trust, previously Chair at Lincolnshire Partnership Foundation Trust, and prior to that I had a career in the third sector. Hi Kevin.
Fantastic, thanks. And Charlotte?
Hi, I'm Charlotte. I'm Chief Executive of National Voices. We're a coalition, we're the coalition of health and care charities in England, and you'll hear from me in a minute.
Fantastic. Thank you, Charlotte. And then Peter.
Well, hello, everybody. I'm Peter Allenson. I'm a principal consultant at the Good Governance Institute. Prior to that, I was the Director of Corporate Affairs and Trust Secretary at Guy's and St Thomas's, had a stint in the Department of Health, and then 15 years in the private sector before that. Thank you.
Fantastic. So different, very different perspectives and a lot of experience here. So I'd look forward to hearing from you. I'll hand over to Paul and we'll go through the panel and I'll come back at the end. Thank you.
Great. Thanks very much, Kevin. And hello to everybody. Just to say, in terms of my focus for the next few minutes, it's quite a niche piece, I think. My focus is going to be on foundation trust governors, their possible contribution to system working, the model of foundation trust governance, and also thinking about non-exec directors' interaction with governors in that system context as well. So if we could go to the next slide, please. So first of all, just to say a little bit about context of who governors are. For foundation trusts, we have a council of governors elected from constituencies drawn from the membership of the trust. And these are usually a mix of public, service user and carer, staff, and these appointed stakeholder governors. So the public tend to represent geographic areas. And to give you a sense from my current trust at the moment, we have got 21 public stroke service user carer governors, 8 staff governors and 8 stakeholder governors. And those stakeholder governors, different foundation trusts have different ones, but they can include stakeholders, for example, from local authorities, from commissioners, from universities, Health Watch, the third sector, etc. So quite a mix there. And if go to the next slide, please. So there are some formal duties that governors have. I won't go through all of these except to highlight the second one there, representing the interests of members of the Foundation Trust and the public. And that's the really important duty that I want to focus on for this session. It's not always easy to do, but it is something that good foundation trusts really strive to reach. So next slide, please. So where I come from with governors is that if we use governors well, they can bring a great deal to trusts and potentially also to us in wider systems. So some of the examples of ways in which we can make good use of governors. First and foremost is really encouraging them to bring forward ideas, issues, and innovations. And I know that that happens within my trust. So for example, things like user involvement strategies being driven by governors, key service developments often driven by governors, sometimes coming up with a good idea that they've seen elsewhere, but sometimes actually putting in challenge about things that aren't working well enough. Thinking about links into our community, that's been another really important one, particularly over the last 15 months or so. So that sense of engagement in strategy design and service design is really important. The caveat I would have, if we're going to make good use of governors, is that the engagement needs to be early enough for those constituents' voices to actually have an impact and make a difference. And that's kind of good participation approach, good involvement, good co-production. You know, I'm not particularly interested in going and asking what people think of a final product. I'd much rather we were having a conversation at the start and really building their voices in. And governors, when working well, have a connection to our constituents, enabling their voice to be heard. And that's a really critical piece of the model. And what we also know is that governors are very often, as individuals, really well connected and active in a wide range of community groups. And I think that that is a really interesting thing for us to potentially tap into. So that's kind of the perspective from a foundation trust. I want to do a little bit of thinking then about how this might apply in our systems. If we could move on to the next slide, please. So as a start point, my sense is that for many of us in ICSs, we're actually still grappling with how we build in the effective scrutiny from our non-executive directors. So that's a piece of the picture we're working with. But I'd argue that we should also keep in mind for foundation trusts, how can governors help hold my non-exec directors to account for the scrutiny work that they're putting into systems? And that then links back to that accountability to our communities. I think it's worth acknowledging that some integrated care systems actually have got a number of FTs, foundation trusts, in them. Others may only have one. And that means that we need to be able to do work at a system level, to be really thinking about how collectively we can make good use of governors. So for example, actually ensuring we've got a shared understanding of that governor contribution is going to be important, particularly for colleagues who are not from foundation trusts, and being able to help them understand the potential, the way the governance works for us, and how the models actually work. I think there's an opportunity for foundation trusts to consider whether or not we have got the right stakeholders around our tables. So actually thinking about stakeholder governors and whether or not we're involving others in our ICS appropriately and effectively. So if I think about my trust at Nottinghamshire, actually, we realise that we've got to revive and review, for example, our third sector stakeholder engagement. I'm very keen that we consider involving our local Health Watch, because Health Watch gives another route into a set of community voices. There are also others thinking about actually, and again, at my trust, right from the start, we had a stakeholder governor from the Chamber of Commerce. Actually, I'm not convinced that that's particularly valid as we look to what we need from our council into the future. And I am actually leading a process at the moment with our Council of Governors and Board of Directors to review those stakeholder governors to make sure we're getting the very best from those. And how they link us into the ICS is going to be an important piece. So part of this then is it's an opportunity for us to analyse which parts of our communities are actually connected into the ICS potentially through our governors, and then where are the gaps? Because the gaps are what particularly interests me about how we then target our community engagement and do that piece of mapping so that we can really ensure that our structures link back and connect to our communities. So moving on to the next slide. thinking about our non-exec directors' interaction with governors. First bullet point, slightly tongue-in-cheek, but not totally. I've had this conversation with a number of chairs over the years. And there's a bit of a sense sometimes that actually foundation trusts get the governors they deserve. There's a lot about if we invest well in our governors, respect their potential, and seek to proactively involve them, I think we tend to get councils of governors that can really contribute well for us. So it's about investing in them and their roles, and non-executive directors are key to this, building those relationships with them. I think it's really important that we're clear about what is the role for governors and what is not their role. That's a very helpful tool to have. And we should also really importantly remember governors are often an insight into the general public. They're not immersed in our NHS speak. And governors are a really good touch point for us to be able to test out materials, papers, resources, and making sure that they are fit for purpose in terms of community engagement. So if you go to my final slide, please. I just wanted to throw some questions out there about how the governor model might apply to ICSs. And I know this is something that a number of people from foundation trusts, as the white paper consultation came out, had thought about. An interesting question, I think, is once we do build non-exec scrutiny into ICS governance, we need to be asking the question of how will we hold non-execs to account for collective ICS performance? And that might be in part through a governor model. There are certainly some pressures around the size of ICS boards. And one model that's been put out there is building an ICS council that mirrors the kind of council of governors versus a board of directors, which potentially enables connectivity to communities, wider third sector and community groups, and also specifically targeting underrepresented communities and communities with poorer health. And finally, they can help us seek an answer to that question. How are we held to account by our communities, and help us take governance closer to our communities? So as I say, a bit of a niche focus to start off, but what I'm going to do now is hand straight across to Dr. Charlotte Augst from the National Voices. Charlotte, over to you.
I'm on mute. Thank you so much, Paul. I don't know, can you hear me? It says unmute myself on my screen.
Yeah, we can hear you. Yeah.
Oh, okay, cool. I think I'll take quite a different approach. So that's going to be interesting to see what people make of it all. But I thought this was very interesting and very instructive, and maybe we can pick up some questions afterwards. First of all, let me explain very briefly who National Voices is. So if you go to the next slide. As I say, we're a coalition of charities. We've got about 170 members. Most of those are patient charities and community groups. A few are professional bodies. Some of those are the very big, all the big names that you're aware of: Macmillan Cancer Sport, Diabetes UK, Alzheimer's, and all the ones that you might have run a marathon for or made a coffee morning or something. But also loads you won't have heard of, unless maybe you have a family member with a specific condition. Increasingly now, through our engagement online and opening our engagement during the COVID pandemic to non-members, we have reached a lot more charities in the regions who normally never travel down to London and sit in a room for a policy discussion. So we are changing, our membership is changing. We're having more members now who look after the needs of specific cohorts of people, homeless people or people who have a traveller background or so on, which is great and really leads to very fruitful conversations. And it's not me who's providing any services to any of those people, it's our members who do. And it is through our connection with our members that we then have the connection with communities and hear what they experience. And we did a lot of listening during the COVID pandemic. So if you go to the next slide, please. When I was tasked with devising my presentation, I was thinking, in a way, it goes to the heart of what political theory has been grappling with forever, really, ever since we've decided that democracy was the least worst form of governing ourselves. It's about who can make decisions on whose behalf, and how do we hold the people to account who make those decisions, and how can we make sure that decisions are made in the interest of everyone and transparently and accountably. And I think Tony Benn puts that really nicely. And I think these are some, you know, whether you agree with him on other topics or not, I think these are very important questions, and I'm going to try to sort of use those questions to ask what that means for the health and care system. So who are you? What power have you got? How will we get rid of you if you didn't do a good job? These are quite powerful questions to understand how powerful or powerless communities actually are about the delivery of their health and care services. So if we go to the next slide, the first thing that becomes apparent that nothing's ever easy in health and care, is it? And I am not myself personally very optimistic that the latest round of reforms is going to, in any shape or form, simplify this system. So what we're dealing with is a tiered system. As I was typing it, my fingers typed the word tired system. I think that probably would have also been correct. But what I'm trying to say right here is that there are obviously tiers, and that, in my view, the questions Tony Benn poses apply to all those tiers. And answers might and should be very different. If we start at the system level, I would have thought most people would not be able to say who leads your ICS system, who leads your STP. I don't know. I'm a health policy wonk. I live on the edge between Southwest London and Southeast London. I don't even know whether I'm in this or that STP, and I certainly don't know who leads it. And I think that is quite indicative, isn't it? That power and accountability dissipates when you don't even know what you're talking about. On an aside, I think that explains a lot of Brexit, but you know, we're not talking about people trying to leave ICSs, but I think if you don't know who's making the decisions, you can't hold them to account. So what does it mean then for the ICS to meaningfully engage with communities? I think there are some big questions there. Place, I think, is where, in my view, most of that action probably needs to take place. Now, the NHS, a bit like the good old colonizers in the 19th century, feels it can just carve up places and draw straight lines, a bit like we see them in North Africa. They don't necessarily correspond with what people say a place is, but I think in many places, a place is a local authority. And I certainly know which local authority I live in. I live in Lambeth. And I think a lot of people would be able to answer the question. There is a lot of people who don't, and that's something that should give us pause for thought. But a lot of adults would know which local authority they live in. And also, I would have thought, know which party's in power, for example, and how to get hold of these people. And there's local councillors, and there is, you know, a website where you can say, my rubbish hasn't been collected, or I think my parking ticket hasn't been issued properly. So there's a way I can talk to these people who are making decisions on my behalf. And I think that is a very different experience as a community member. As a representative who knows a lot about the VCSE, about the voluntary and community sector, I think what's also important to remember is that the places where most organisations in the voluntary sector would have a commissioning relationship with the commissioner. As an aside, most charities don't have a commissioning relationship with any commissioner. Most charities work out of charitable funds and do their good without being in a formal relationship with a statutory commissioner. But those who do, and those are the charity names that you know of, some of the national ones, Mind and Educate, but also a lot of local ones, will probably hold that relationship at the place level. And I think that, again, should inform where we think most of the accountability should be built in, because this is where decisions are being made for populations and how their needs will be met. I think it's important to also mention neighbourhood, and roughly, I think in the NHS jargon, that means the footprint of a PCN. Now, again, I know where my GP surgery is. I do not know which PCN it belongs to. And do I need to know who is running my PCN? Can I tell these people how I think they should run it? I doubt that. But I think it's at that level, obviously, where people could, at least in theory, have very granular insight into the communities that need to be served in this patch. And also the assets this community brings, that there is a school there, and that school has a lot of Somali children, and that if you want to talk to Somali parents, that might be a good place to go. So I think it's at that level that we can really match up the assets we have in the communities we're trying to serve. And that is obviously really useful knowledge, for example, if you want to get the vaccine to people. And then I'm very aware that you are all affiliated one way or another with providers. And I think they are really interesting because they don't really feature all that strongly in the legislation in terms of their responsibilities to engage. And there are, as we've heard from Paul already, provisions for governance arrangements. But I think, again, most people wouldn't know where their local hospital is. And it's a real thing. I think the chances of there being a dialogue between communities and a service provider are higher than they are necessarily for communities and a system, because people feel strongly about the hospitals, as you all know, and they feel strongly about the provision of mental health services and community services. And there is a sense that this is a real thing and that there will be some real people in charge of this real thing, which is a good starting point for accountability. So if you go to the next slide, where I unpack accountability a little bit more, we have already heard from Paul about board representation and governors, and we are mildly alarmed that what it looks like at the moment, with CCGs and trusts at the moment being obliged to have so-called lay members on their boards, there does not seem to be the equivalent provision at the moment in the draft legislation, at least as we understand it, for the ICS level. I think that is a problem, and the requirement that there should be so-called lay governors on boards is not in itself a particularly strong one. And I think Paul acknowledged that it can be very tokenistic and doesn't always work, but at least it's a starting point. So we will really look out for that minimum requirement not to drop out of any legislation. There's also obviously a duty to engage, and many of you will know that if service changes need to happen or if things need to be procured, you need to engage. Now, the legislation seems to suggest we should do a lot of less procuring. That means we probably will do less engaging, which is fair enough, because I think these formal set pieces are not necessarily the way that you really hear from the communities that you need to serve. But what we find alarming is that there is a slightly glib provision in what we've heard that says, if the NHS agrees that the NHS is providing a good service, slightly paraphrasing here, they don't need to procure services. And I think, well, who's best placed to decide whether the NHS is providing a good service? And, you know, would the young people who don't feel like they can access mental health services, or would the women who can't access eating disorder services necessarily argue that, yes, this is a good service and no, it doesn't need to be re-procured? I think this really poses some questions about whose quality is it anyway? And what we don't want is an overly cozy arrangement whereby we hand money to the NHS and basically say, see what you can do with it. And that's the amount of accountability that we manage to build into the system. Insight is another really important plank of accountability. Do decision makers understand what's actually going on? Do they hear from their local VCSE, for example? And I thought Paul made a really strong point that there is a responsibility to also understand the gaps in this, because the inverse care law, I'm sad to say, is alive and kicking in the VCSE itself, and often very deprived communities do not have a voluntary sector organisation or a community sector organisation who supports them and who can advocate for their needs. So there is a need to provide some oversight and to understand who's actually well served around here, including by the community sector. And finally, and that leads me into the point around voice, do we hear always from the same retired, middle-aged, middle-class white people, or do we hear from voices that are easier to ignore? So have you heard from young people who find it very hard to access mental health services? Have you heard from lonely older people? Have you heard from people living in certain estates, and so on? Which leads directly to the inverse care law. Right, before I wrap up, I thought it might be useful to zoom out a little bit again. If we go to the next slide and ask ourselves the so what? Why do we even bother hearing from people and communities? Why do we think that's important? Because I think maybe in the heat of the moment, sometimes you might all think, well, what's the point of all of this? And I think these two images might sum this up quite nicely. So I live in London, I'm a cyclist. London roads have been designed for cars, and that means London cyclists get killed. And the truck driver who's just driven over a bike there, hopefully not the rider of that bike, clearly doesn't get into his truck in the morning with the intention of killing cyclists. But there's something about the design of roads that is predicated on an assumption that all people move around London in cars, when actually most people don't. And also then decisions are made about the design of roads that put the lives of cyclists at risk. And that means that the truck driver has a blind spot where he's not aware, where they're not aware that there is a cyclist next to them. And we have tried to turn this around in London in recent years. We have started building architecture and infrastructure that makes cyclists very visible, puts a barrier between them and cars, and we are managing to keep cyclists safer. And this is to do with having heard about this type of road use and having acknowledged that our assumptions about how people move across the city were wrong and were putting people at risk. And I think this is directly applicable to healthcare. We're making assumptions about what people need. We're making assumptions about how they use health and care services. And these are wrong assumptions on the whole, if we haven't bothered actually going and finding out and making visible, pulling out of the blind spots, those people who are most likely to get harmed. So even further out, if we go to the next slide, I do believe that we're a long way away from health services of the people, by the people, and for the people. And I do also not believe that this legislation will ultimately deliver that. But I do think it's an opportunity, this legislative reform process, to ask those questions and make sure that they don't drop off the agenda of what otherwise might become a very internally focused discussion between health and care services. Right, that's it from me. I think what I need to do now is to hand over to Peter from the Good Governance Institute. Over to you.
Charlotte, thank you very much. And I want to pick up a couple of points that you were making about the mix of voices and assuming that we know what people need from the NHS. I was told a long time ago that assumption is the mother of all muck-ups, or at least one version of that. So what we are, of course, in the midst of is a change process. We've had lots of change processes. Are we used to change? Well, I think probably we are, because it's with us all the time. But one thing that we just need to remember about change is that it's progressive. We're not going to wake up tomorrow morning and find that the job has been done. So there is a balance to be struck, and that's sort of what we must carry on with against the opportunities to build something new and different. And those two are not mutually exclusive. And I think that sort of lies within this particular set of dilemmas that we're facing at the moment. So if we could move to the next slide, please. So I just want to remind ourselves, because these words have been mentioned this morning, about what the difference is between being accountable and holding to account. Now, of course, accountable is a legal liability. It is something that you are responsible to somebody else for, and you are certainly on the hook for, as it were. And if you're a non-executive director, you are accountable for the performance of your organisation. Holding to account, however, is a different process, and it's about seeking information, evidence if you like, and that's done on behalf of others. It's not actually holding the responsibility yourself, and that's very much what the governors do. Both of these are continuous processes, and I think whether it's governors or others who are doing the holding to account, it is something that needs to continue. Can we move to the next slide, please? Now, on the face of it, these processes are not going to change with new systems and with system working. But I think it's important to remind ourselves that the context will, because the way care is going to be planned, paid for, and delivered is going to change. And taking those things together, you've got individual organisations, but also a further layer of responsibility. Next slide, please. So, whilst services continue to be commissioned or planned or bought, however you want to describe it, of course, providers will still be there and will still be providing. And so the holding to account is going to be needed. And there is a continuum of local reassurance that is going to be needed in whatever sort of environment we find ourselves in. But ICSs are coming. So next slide, if they've not already arrived. So I just want to sort of perhaps throw a little pebble in the pond here and ask whether we're in fact being a bit too modest about our ambitions here and missing some opportunity. I think we've probably got an opportunity to alter mindsets. So if a system is truly working together and is looking at delivery, there's more we can do than take the easy option, which is to focus on mechanics and to hide behind the bureaucracy that inevitably you'll find in the health service, and indeed using governance as an excuse for inactivity. Now, governance is often used as an excuse for response, for rules, for responsibility, for doing things. But the origins of the word governance go back a long time. One of the origins is of the gubernatore. This was the steersman, the helmsman, who stood on the deck of the Roman galley while everybody was slaving away underneath. And what was he doing? He was looking out to the future. In other words, he was strategizing. He was seeing, where are we going? And more particularly, he was also assessing the risks that were going to prevent you from getting there. That, I think, is the right context for governance, and certainly in this arrangement. And perhaps looking at Paul's stakeholder expansion point, I think we ought to be braver. I think we ought to be thinking about some sort of civic renewal. We ought to be challenging our risk thinking and making the profile more inclusive across the system and across its institutions. I think we should be asking people questions. Let's ask citizens questions. Let's get them to be involved in our policy, in the development of local healthcare policy. Let's ballot them sometimes. Let's have a broader assembly. So if we could aim for local health policy to be driven by views taken locally that embrace voice and community as part of the public health agenda, I think that we could deploy ICS resources much more imaginatively to deliver this. So next slide, please. So of course, clearly the best way to collaborate, and collaboration I'm defining as going beyond the institutions within an ICS, is to try things out, widen engagement, co-produce, and with NEDs and governors' voice. And it's something for governors to take back to their constituencies and talk to them about. We often suggest that there should be conversations, and it is quite difficult to pitch a conversation unless you've got some sort of topic base. I like the idea of a permanent assembly, a sort of ICS council that listens to the authentic and authoritative voice. And it can distill the campaigners, make sure that it's focused on a broader range of opinion and thought so that it delivers for patients and service users. And one set of voices that I just want to shout up for are clinicians. Now, this is a set of voices that must be heard and need to deliver change because, of course, they are the people who know how to deliver in clinical and medical terms for people. So where might this take us? So I think it will take us to reassess where and how treatment takes place. I think it'll help us to recognize the importance and significance of soft intelligence to supplement hard evidence, not replace it, to supplement it, and to work out what communities are saying and why they are saying it. In other words, there are opportunities regardless of the mechanics. In fact, what I want us to do next system is to carpe the system. I'm sorry about that, but seize the system, I think, is a call to arms which we should be listening to. So next slide, please. So I think this is an opportunity to see change, to enhance involvement, widen the scope for listening, increase the number and the types of voices being heard and paid attention to, and enabling different communities that you go out to, and not forgetting staff, and I've mentioned clinicians, which are a whole set of communities in themselves. But I think let's just remember that the whole point of this, the whole policy thrust, the whole development of place, the aim is about quality and outcomes and improvement. Accountability and governance are merely side helpings. And let us make sure, to misquote Charlotte, that it doesn't all end in tears, however you care to spell that. Thank you. So back to Kevin to take over.
Hi, we've just lost Kevin for the moment. If someone could step in, that could be great.
I'd spotted that there was a first question that was in. Perhaps if I read that question out and give a first response to it and see if the other two want to come in as well on that. So it's a question saying there's something comforting about regular tiers, but place, ICS, collaboratives, regions are all different footprints, and is not the resulting bureaucratic burden overwhelming for both executives and non-execs. I know certainly my take on that is that actually, yeah, what we have to do, I think, is manage both. We have an understanding of the resource capacity we've got to bring to the table in our senior leadership execs and our non-execs, but also then map that against the demands and really hold on to not losing sight of our statutory responsibilities. I think there is a risk that if we put all our resource into being a good system player, we risk losing a focus on our statutory responsibilities. And I guess I'd say that there's a responsibility for us to absolutely not design a bureaucratic burden that's overwhelming, and to really think about what I might call a proportionate bureaucracy, which potentially can be aided by clarity in what's being done at which level. And one of my measures of that is if the same people are meeting under a different title at the different tiers, then we've got that wrong. Charlotte, I don't know if you want to come in on that. I think Kevin's back in. So
I am back.
I'll
let you guys run. My router went down, I think. Yeah, I'll come back.
I've got some thoughts about the bureaucracy. I think I sort of hinted at that, but the sort of beating heart of engagement should be at the place level. This is meaningful to people and communities, and this is where the VCSE has invested into infrastructure. We've got councils in community at that level, and there is a community infrastructure that can enable meaningful engagement and accountability. I also think that, the good old-fashioned joint strategic needs assessment could play a really big role in driving plans both upwards and downwards in these tiers. And so my sort of temperamentally, I'd be inclined to say, let's keep system governance, accountability, engagement quite light touch, and keep it about enabling this to happen at place level and challenging it to happen at place level, because obviously it's not going to happen equally well everywhere. But then, I've been around health policy for 20 years now in this country, and I'm cynical enough to also appreciate that I think there's a real risk that ICSs, or potential that ICSs basically become enforcement bodies for the centre, for NHS England, and for the Department of Health, and that therefore this is where all the decisions are going to be made. And that is obviously a very unfortunate outcome, because I don't think that will really empower communities or stakeholders. But if that's the case, and we've not built any engagement mechanisms, then that's a real problem, because then people are frozen out. So ideally speaking, if I didn't understand the politics of it, I would say, let's just keep the engagement and the governance really light touch at the system level, because we have business to do here, and we have to understand what the people of Lambeth and the people of Devlin and the need. But knowing what I know about politics, I think that's a high-risk strategy.
Thank you. And then we have a comment from the floor, I think, rather than a question. The change of focus from competition to collaboration should mean that we have to be more nuanced in how we think about accountability and how we relate to NEDs users and patients in that context. I think you talked earlier in the call about commissioning. The change in commissioning means that there'll be less of that going on. So we have to think in different ways about how we engage. I don't know if you've got thoughts to build on that, either Charlotte or Peter.
One thing I always say at this point is that for me, collaboration is about making yourself accountable in a horizontal way. The CCG makes itself accountable to a local authority, and a local authority makes itself accountable to the CCG. You deliver a promise, you deliver on it. This is how good collaborations happen. You say, why don't we do this? And then you do it. And I think there's a problem with the NHS being quite challenged around this, because they get pulled up into a vertical accountability always. And if your accountability is always upwards, and you always have to say, this is how much we reduce the deficit, and always upwards, then it's very hard to build very strong links horizontally, because you get pulled out of the commitments you've made to the people you need to actually work with in order to deliver good collaboration. I think that is a birth defect of how we've configured the NHS. But I shut up now. Other people might have
it's very helpful. Thank you, Peter. Any thoughts?
No, I think that's a very wise point, that the tension between delivering your local requirements and delivering across a broader geography is one that we'll have to get used to. I mean, we've sort of been trained over the last, goodness knows how many years, to compete and to be accepting that a trust with a legal personality has got to do its best for itself, compared to what is now being sought, which is probably closer to Beveridge's view of what the NHS might have been for. So I think that there's a lot of learning for the system to do, and it's not going to get it right immediately. And certainly the second that it turns, that the ICSs turn themselves into any sort of quasi-regulatory activity or something that working on behalf of the centre will, I think, pose problems that it'll take longer to solve than it will to cause.
Yeah, thank you. And I'm interested in that up-down accountability, and one of the conversations that we're moving into is health inequality. So COVID shone a spotlight on that in a very focused way, in terms of how the vaccine and the virus are impacting in different ways across different populations. To what extent does tackling health inequalities present an opportunity to hear different voices? Charlotte spoke about that, I think, quite eloquently in some of her presentation. I'm just interested in other perspectives as well, and obviously bring back Charlotte too.
I'm happy to give a perspective. Just some of the learning from the last 15 months actually is that if we look at where we've seen health inequalities exacerbated by the pandemic, where we've seen a spotlight on health inequalities through low take-up of vaccine, then actually we can learn from that about how we reach those communities better. So an example I'd give in Nottingham City is that by triangulating data from vaccine programme, from primary care, and from our local authority partners, we've been able to then develop a vaccine bus, literally a bus, that goes to right down to postcode and street, and to be able to go to a street with people who are able to have a proper conversation with a community that we probably have left behind in terms of that program. So I'm not a particular advocate of, oh, this is all about vaccine hesitancy. I think this is about how we engage with our communities. But actually the success of that bus has been to have those conversations, and then to be able to offer up, if somebody then chooses to say, actually, I think I'd have a vaccine, they can do it there and then. And that to me is a real opportunity for us to have connected, thinking about aspects of health inequalities.
Thank you.
I think that one of the debates that needs to be held within local systems is around this very point of health inequality. And it actually is a slightly different point. It's whether it is now appropriate for acute hospitals to be seen as the lead health provider in any part of the geography, and whether either a healthy cooperative collaboration of them all, or whether shifting the emphasis towards community, towards primary care, is the way to go. I think it's quite difficult to pull off given the sheer financial weight of a large acute, but it is something that needs to be talked about. And some models where you've got acutes providing community care is one of the ones to look at, because that helps to rebalance the focus. And could I just say that I'd like to pick up Daniel Shefford's point when we get to it?
Yeah, absolutely. I'm going to come to that next. I'm just conscious, Charlotte, you might have a thought on
just very briefly on the inequalities point. I think what we've learned is that all the might of the NHS, and what a might it has proved to be, its huge workforce and its huge ability to leverage research and money, doesn't reach certain people, and that you do need that little minibus from the mosque, and you do need the language volunteer and so on. And an example I always use is in South Manchester. I've worked with a number of language volunteers who called people, and those people had been invited through standard communication, then chased by their GP and had still declined the invitation to have the vaccine. And then the language volunteers managed to get them along. The language volunteers also attended the vaccine centre and could answer any questions there. And I think that's obviously wonderful, but I don't want us to stop there, because this way of working, we're at risk of turning the community sector into this sort of transactional provider of, they can do a translation. Actually, what we know about this community, and that's the point Paul made, is we probably know that those people won't have done their cancer screening, they probably don't turn up for their flu jab, they probably didn't have a carer's assessment, they probably haven't claimed the benefits they're entitled to. Wouldn't it be wonderful if we could work with the community organisations who've just managed to reach these people to say, we probably could do a whole lot more with and for you, and could improve your health outcomes and could go alongside you, because we've just got the vaccine into their arm, but that's just that transaction. Really what we need is a different relationship between these communities and the big NHS system. And community organisations could provide that bridge and build on that relationship, do a home visit, book in a home visit and have a chat about what else is going on in a way that feels non-threatening. But we need to enable the VCSE to work in that way and to commission it in that way.
Yeah, thank you, Charlotte. And I also was remembering, I think it might have been Peter talking about qualitative feedback and information as well as quantitative in that context. And I love that kind of point about the horizontal accountability there, Charlotte, as well, in terms of your promises to each other, as well as up on targets and measures and what have you. We'll turn to the question that we've got in the chat space. If we had a blank sheet of paper, would we go down the governor model we've currently got, or would we do something different? And would welcome sort of a point tacked onto that, which says, is this about primary legislation, the need to change that, or is there kind of other things we can do there as well? Views welcome from the panel. Peter, I think you expressed an interest in it, so I'll let you go first and I'll come round.
Yes, thank you. I mean, there are two aspects of the delivery of healthcare which governments refuse to tackle because they're going to provoke fierce arguments, leading to the question, which is a perfectly reasonable question, is the game worth the candle? So there's one, do you want to take on all the governors in the FT world and have a huge argument with them about either changing them radically or sort of getting rid of them? I mean, I'm sure you wouldn't come up with this model if you had a blank sheet of paper, though of course somebody did fairly late at night, I think, back in 2002, when they were doing the draft legislation. And of course, I can't resist the temptation of reminding everybody that the other bit that no government's prepared to tackle is the question of bringing GPs actually into the health service as opposed to being contractors to the health service. So I think that's partly why I was talking about, are we being a bit wimpy about the ambition we have for working with communities and getting different voices in. Because, of course, not every health body has a council of governors. And as Paul said, you get the governors that you deserve. So some have got a really good set, others haven't. So it's not a very good answer, but it sort of gets it off my chest. Thank you.
Yeah. So just probing a little bit on the kind of legislative point that's in this question, do you think we need to change? Does legislation need to address this, or is it something that we should do outside of whatever bill is coming in this space?
You can't fundamentally reform the governance system without changing the legislation. You can, of course, work with it. You can add to it in different ways. So the answer is, if you want to do something completely different and completely radical, you'd need to change the legislation. If you want to do it quietly by stealth, that's what you continue to do.
So we, in one sense, have to wait and see what the bill says. Please go ahead.
I think I'd echo much of what Peter was saying there. I think from a position as an FT chair, for me, I think it's about us making whatever we can within the constraints of the legislation work to the best effect. Personally, I wouldn't be for trying to put a load of energy into redesigning a layer of governance that I would then have to start to have battles with others about in terms of legislative context. I think my energy and the energy of my governors, my board of directors, is much better put into how do we make the model that we've got work as well as we possibly can. And I do think that part of that is asking ourselves honestly about what is it that we as organisations do to give us the councils of governors that we have. And I do think that there's a really important piece as well about having conversations with our governors. One of the interesting pieces about, I know somebody had asked about how we prepare governors around the transition for them to have a focus on systems. And one of the questions I would ask is, do we actually have a conversation with our governors about all of their other links into our communities? Because I'm sure that there is a massive, immediate, untapped resource, which then helps us map some of those gaps that you were talking about, Charlotte. But actually, us being able to understand, actually, in our governing bodies, we do have these connections into, for example, faith groups, community groups, groups that are based around small local charities. And those can potentially be something to really enhance what we do. But I think us working with our governors, helping them understand what a system actually is. And as Charlotte said, actually the public and probably many of our governors too, by nature of being a step further away, actually levels of understanding of what our ICSs are trying to do. Of course, will need us to be putting energy into that. But I think there's a lot about us having good conversation and being able to listen and ask good questions, not just be presenting to our governors.
Thank you. Charlotte, please, yes. And then I'll come back. There's a question for
I
Paul,
think
but I'll put
this surfaces an interesting tension, and that in a way, the justification the NHS is bringing towards asking for legislation is to say, yeah, we can work around the existing arrangements, but it would be so much better if we tidied these up. And, you know, the government in response keeps saying these are the reforms the NHS wants. So I think it's interesting to hear from our two participants here that they're saying, oh, let's just leave it the way it is and we can just work around it. Because the whole point of starting this legislative proposal is that we can't leave it and we can't work around it and we need to legislate. Now, I'm not sold on this full stop. I go to endless meetings in NHS England. Literally the best and brightest people NHS England have are now beavering away on organograms trying to describe what the relationship is between the ICS and the partnership board. And I think I'd rather have those bright brains on other questions. For example, restarting electives. So I think, you know, there is an interesting tension there. And I do remember Frank Dobson saying all those years ago, the real life problem that a foundation trust is the answer to has yet to be invented. And I think that sums it up quite neatly. But we are where we are. And I think zooming out, it's probably best not to open this kind of worms, as Paul and Peter have said. And I think there are other creative ways in which we can make this work. And that's probably the note I should finish on, is to say, you know, there are citizens' assemblies, there are mechanisms for insight that people can invest in through the health watches, through their community councils. Really what we need is a thriving network of relationships. And I think governors are an interesting one to think through where they fit into that, that enable you to hear from people who are a long way away from the decision-making room that you sit in.
That's really helpful. And, there's sort of two or three things that are sort of running around my brain as I listen to this. One is, we're going to have some sort of structure. As you say, there's people working on organograms and stuff, so we're going to have to work with that. I am very interested in outcomes. you know, your elective point being one, and I also asked a healthcare question, and your clarion call about listening to different people in that context, I think, is really important. So thank you. Finally, we've got just a couple more minutes yet, so I'm just going to ask that final question about how can we, you know, it is back to a governance question, but how can we prepare those who are helping hold the system to account for what's coming up? Are there simple practical things that we can do to help prepare our current governors for what lies ahead?
I certainly think there are. I think first of all is making the proper development time to have the conversations, not just doing it in formal sessions. So having conversations. The piece that I said about understanding the breadth of our governors and what they can bring, really seeking to develop a shared understanding. And one thing that I don't think we've mentioned as well, which I think is an interesting one, is bringing together councils of governors with other councils of governors, and actually governors having conversations with themselves, and finally with other potential representatives. Thinking about a big one we've not talked about is our local authority and their democratic mandate. And actually there is connectivity there that I think as an NHS, speaking very broadly, we've not engaged effectively with over the years.
Thank you. Peter, final thoughts?
Yes, I think that's absolutely right. There are lots of conversations that should happen. The voices that I think we should not forget actually are non-executive directors. I mean, in many instances, they're in as difficult a position, if not a more difficult position, than governors. And having to understand something as complex as a broad system is different from understanding the complexities of the organisation for which you are a non-executive director. So I think that there's a range of discussions, a series of debates. I think there should be single topic discussions. I think there should be much broader ones. And I agree that thinking how you can enable local authority colleagues to play their part is as challenging a question as anything else, because of course their accountability is really rather different, and therefore the motivations can be rather different. But the other thing is that this has got to be a progress. It's not something that's going to happen overnight. And I think you have to keep your eye on the prize, which is an improvement in the services and the quality of what's done for people who use NHS services for whatever purpose. It's not about accountability. It's not about governance in itself. Those are a means to an end, which is to improve what happens to people using services.
Thank you. And some nice comments coming through from the floor as well, saying it's not just about the governors, it's staff and other stakeholders too engaging. Charlotte, final thoughts, and then I'll just thank everyone and close.
I think I'm fine. I don't have much to add to Paul and Peter.
Thank you. All right, we're on time, so thank you very much, everyone. Great questions from the floor. I'd really like to thank the panel, both for your time and your wisdom and expertise, and obviously you're engaged in the healthcare system deeply in your daily lives. So thank you for all of that too. Very grateful for coming here and sharing your insights.